Good morning, everybody. It is lovely to see you again. It's nice to have slightly more full room this time. Today we're going to be talking about a couple of really interesting topics. We're going to be talking about language, about spatial functioning, because as you know, language tends to be a more left hemisphere function, although not only left hemisphere. And spatial functioning tends to be more right hemisphere, although not only right hemisphere. And we're going to be dealing with emotion, and then a combination of plasticity and rehabilitation. Okay. All right, let's start with the language. Aphasia is difficulty speaking. And if you look in the Derby and Walsh books, they have a specific definition for it, which is acquired impairment in the reception, manipulation, or expression of the symbolic content of language due to brain damage. Now, I just want to break that down. So it's acquired impairment. In other words, it didn't exist before. So aphasia, a person doesn't have aphasia if they're born with speech difficulties. Okay? In the reception, which means listening and understanding. Manipulation, which is the use of language, like with poetry, puns, that kind of thing. And the expression, which is speech. Symbolic content. Now, symbolic content, when we think of language, we think mostly of letters, which are symbolic. But it also applies to other symbols, like numbers, due to brain damage, such as traumatic brain injury or stroke. So again, aphasia is not something you're born with. If you're born with a language problem, it's not called aphasia. It would be called something else. That is the definition of aphasia. Now, sometimes one gets confused between aphasia and dysphagia, mainly because in a lot of texts, the words are used interchangeably. Aphasia, A, meaning not, phasia meaning speech, aphasia means that the person cannot speak, there is no speech. Dysphasia means it's abnormal, difficult or impaired. So that would be impaired speech. So you say somebody is aphasic if they cannot speak, or they have dysphagia if they have difficulty speaking, but you'll see in the text that aphasia and dysphagia are often referred to as the same thing. Okay, now, part of what you're going to be learning in this month are the many, many different types of aphasia. So I'm going to be touching on a lot of them. I'm not covering all of them. But these are some of the main ones, and I'm mentioning them so that when you do read through it and you do study it, at least you've heard it before and it's not completely unfamiliar to you. So you get, I think we all know about Broca's aphasia, also sometimes referred to as motor aphasia, which could mean that somebody has complete loss of speech, or that they have some difficulty with speech. Sometimes it can be very subtle, for example, that their vocabulary is affected, and that's the only thing that's affected. They can also have agrammatism, which is loss of grammar, so they would be able to say words, but not have those fillers that make up a sentence. And they might have agraphia, which is not being able to write. Then, of course, you get Wernicke's aphasia, which I'm sure you're also all familiar with it. And you can see in that yellow part that depending on which diagram you look at, Wernicke's aphasia is not always that clearly mapped. So in this particular diagram, this yellow part, you can see it's quite a big area. And the reason I chose this yellow diagram is because it helps explain the different aspects of Wernicke's aphasia. Now, Wernicke's aphasia is a sensory aphasia, the sensory, with the hearing, and it is a loss of association between words and their meaning, because they cannot hear what they are saying. So because people can't hear what they're saying, they don't make sense. So the person speaks, but their words don't make sense. And you get auditory receptive aphasia and visual receptive aphasia, and they're both a type of Wernicke's aphasia. Now, your auditory receptive aphasia, the person has difficulty understanding what is said to them, and the area is the superior temporal convolution. Things superior, you know the temporal lobe by now has 3 different areas, so you're looking at the superior temporal convolution. That is where you get the auditory receptive aphasia. Then you get your visual receptive aphasia, where the person has difficulty understanding what has been written. And you find that in the parieto-temporal region. So in the temporal lobes, between the temporal lobes and the parietal area, of course on the left, not on the right. Just something to be aware of, the word alexia means it's word blindness. You actually just, you can't, it's like you can't see words. Dyslexia is a developmental reading difficulty, and we're going to be talking about dyslexia quite a bit later on. And then you have alexia without agraphia, alexia without agraphia, where the person cannot read, but they can write. So, if you think of Wernicke's aphasia, there are many different aspects to Wernicke's aphasia depending on where the injury is. And it can present in many different ways. But ultimately, it is a sensory aphasia. Then you also get global or mixed aphasia, where you have both motor and sensory aphasia. Now, if you think of the brain, you think where Broca's area is and where Wernicke's area is. For both of those areas to be damaged, you must have quite extensive damage and very large lesions. So, these cases are severe with extensive lesions, and we probably as neuropsychologists won't see those cases because they are probably just too injured for us to even really assess. There wouldn't really be any point in it. Of course, one would see them in a rehab setup. Now, you get amnesic, anomic, and nominal aphasia, and they all mean the same thing. Okay. Just to keep life interesting. So if you read in one book about nominal aphasia, in another book you read about amnesic aphasia, they're the same thing. Okay. And ultimately it means that the person has naming difficulties. They have difficulty giving the names of things. So they'll have difficulty thinking of names of people, and I'm not talking about the normal day-to-day difficulties we have thinking of people's names. This is quite a severe disorder. Or they have difficulty identifying objects by their proper names. And what often happens if you have a client sitting in front of you with naming difficulties, you have a phenomenon called circumlocution, where they talk around the point. If you think circumference, around about, circumlocution, they're talking around the point. It's an indirect way of talking, using an unnecessary amount of words to describe something instead of just saying the word you're describing. Now, in practice, one of the ways that this often comes across is if you're doing the vocabulary test in one of the Veshta tests, and you ask somebody, what does this word mean? And they talk all around it. You can hear that they know what the word means, but they can't really get to the point. And I found this little illustration which I thought was really cute because it explains it quite nicely. You've got a box and the person calls it a cubic containment system. Or you have an eraser and they call it a misapplication elimination device. Or you have a comb and they call it a follicle redistribution mechanism. And a swatter is a vermin de-infestation apparatus. And then your bed is your horizontal tranquility terminal. Yes. Of course, when you have a patient who has circumlocution, your assessments tend to be very long. You sit in because you listen and listen, but you can't interrupt them because you need them to say what they need to say, so that you can mark whether they understand what you're talking about, but it just takes them very, very long. You need to have a lot of patience. All right. Then we also have what you call conduction aphasia. Now, conduction aphasia is when you have a lesion along the arcade fasciculus. Now, you know where the arcade fasciculus is? It's those band of fibers between Wernicke's area and Broca's area. And you can see it in the grey brain over there. And then in the DTI scan, the red band is your arcade fasciculus. Now, if you have a lesion in the arcade fasciculus, you have what you call conduction aphasia, where the person has intact understanding of language. They understand what you're saying to them. They have intact speech. They can speak. but they have an impaired ability to repeat what has been heard. And so, for example, in practice, they can't pass on a telephone message. They might listen, hear what the person is saying on the phone, they understand what the person is saying, but they can't then go and repeat what they've just heard. Okay. Then you get transcortical motor aphasia. This is where it becomes a little bit more complicated, where you have anterior lesions beyond the inner perisylvian language area. Now, I know that sounds terribly complicated. What it really means is it's really just in front of the Broca's area, anterior to the Broca's area. You have damage there, but Broca's area is intact, but just the brain area around that is damaged. And it can cause motor speech difficulties, as with Broca's aphasia, but with preserved comprehension and repetition. So you understand, because Wernicke's area is intact, your arcuate fasciculus is intact, so you can repeat things, but you have difficulty speaking because of the brain areas around Broca's area have been injured. So the patient, for example, might not be able to say, I am thirsty, out of their own, but they can repeat, I am thirsty. So if you go to a patient like this and you say, I am thirsty, they will say, I am thirsty. But they won't out of their own say, I am thirsty. Okay. Then you get a transcortical sensory aphasia, where you have posterior lesions near and around Wernicke's area. So Wernicke's area is intact, but you have lesions around that area. And when that happens, the person can repeat words and sentences they hear, but they can't understand what they mean. Okay, so they can speak, they can repeat what they're saying, but they don't understand what they're hearing. So they cannot understand what is being said, such as good morning, but can repeat what is being said. So if you go to a patient and say good morning, and they say good morning, they might just be repeating what you're saying, and they might not really understand what good morning means, and that you're really greeting them. Okay, then you get mixed transcortical aphasia, where both Broca's and Wernicke's areas are spared, so you don't have damage there, but they are isolated from the rest of the brain, or the language association areas are damaged. So Broca's and Wernicke areas are intact, but around them there's damage. And if that happens, speech production is impaired, they can't speak properly, auditory comprehension is impaired, they don't understand what they're hearing. The ability to repeat spoken words is intact, because the arcuate fasciculus is intact. And interestingly, they can sing songs that are familiar to them. I read an interesting chapter in one of Oliver Sacks's books recently. He wrote a book called Musicophilia, where he pointed out that a lot of aphasic patients, although they might not be able to speak very well, they can sing. And if you can just encourage them to sing along, to sing songs, it encourages them so much to try and speak, and it just lifts their spirits. And with some of them, it actually helped them to learn to speak better too. Now we know language is mostly in the left hemisphere, but there is also a right hemisphere contribution to language. And that is that if you had to block out, let's say you block out the left hemisphere, it is disconnected or ablated, or it's just not working. The right hemisphere can recognize words, but it has little understanding for grammatical rules and sentence structure. So it will not be able to, the right hemisphere cannot put together sentences. So it really cannot put together language, but it can recognize words. And interestingly, and I don't know why this is, and the Colburn Wishaw don't explain why either, perhaps more research needs to be done into it, but the right hemisphere has good auditory comprehension of language. And then a very important part of what the right hemisphere contributes to language that the left hemisphere can't do at all is prosody. Now, prosody is the sing-song sound of our voices. So the rhythm of our voices, parts of the sentence that's stressed, intonational speech, the emotional state of a speaker, the form of the utterance, example, whether it's a question or a statement or a command, the presence of any irony and sarcasm and emphasis. So, for example, you can go to a person and say, that was a nice thing to do. Or you can say to him, that was a nice thing to do. You're meaning two completely different things, but the sentence is the same. The left hemisphere only hears, that was a nice thing to do. The right hemisphere picks up whether you're being sarcastic or if that's really what you mean. Now, third, we're going to talk about dyslexia. Now, the lay person's perception of dyslexia, I don't know if it still is the case, but I hear people often talk about this, is they think it's children that switch letters in when they write. That's not dyslexia. That may be a slight aspect of a form of dyslexia, but that's not what dyslexia is. Dyslexia is a difficulty or an impaired ability to read, and there are very many reasons why one might struggle to read. And in Coleman Weshaw, they name these 6 different types of dyslexia. The first one is attentional dyslexia, and that is when one letter is present. If one letter is present, then naming is normal. But if more than one letter is present, naming is difficult. So if you say, let's say I have an A on a page, the child, because it's typically a developmental problem, the child will say it's an A. But if you have CAT, they can't read the word because they're distracted by too many letters together. They can't pay attention to the whole thing. Then you get neglect, when the first half or the last part of a word is misread. So, for example, you read mother instead of brother, where you're picking up on the last part of the word and you're just substituting something for the front and reading the wrong word as a result. Then you get surface dyslexia, where the reader cannot recognize words directly, but they need to sound them out. Spelling is impaired, but is phonetically correct. Surface dyslexia does not develop in languages that are totally phonetic. So it is a difficulty with recognizing a word for what it is. This is a difficulty that children have if they have surface dyslexia. Deep dyslexia is when the reader makes semantic errors, where they read related words instead of the words that they're meant to read. So they say, it says Merry, but on the page it says Merry, but they say Christmas, because they have an association between Merry and Christmas. So they're not reading what is being said, but an association is coming up. And verbs, which are your sort of function words, present the greatest difficulties for people with deep dyslexia. Then you get phonological dyslexia, which is an inability to read non-words aloud. Words like blog, merg, spog. There are no such words, but we can read them because they're kind of, you know how to read words that you've never seen before. But somebody with phonological dyslexia won't be able to do that. And then you get letter by letter reading, when the reader spells words out to himself. And obviously that slows the person down tremendously. Now, looking at all of this, how does one apply this in a neuropsychological assessment? Well, just in the general conversation you have with your client, you might start picking up on some language difficulties that they have, and the way that they respond to instructions. If you realize that they're not understanding the instructions, then you need to start asking yourself, why are they not understanding? Are they hard of hearing? Did I not speak loudly enough? Is it that they don't speak my language and maybe I should have had an interpreter? Or do they have some sort of language difficulty? With a vocabulary test, one can look at the vocabulary to some extent. Well, I think our vocabulary tests that we have are very limited in our use in South Africa, and even the SSR, I think the vocabulary words there are so outdated that the children that we test nowadays don't really use those words or hear them all that often. So one has to be very, very careful with the vocabulary test. And then we have the token test. I don't know if you know the token test, where you have little circles and squares of different colors and sizes, and you start off giving instructions that are very simple, such as touch the white square, to very complex, such as pick up the green square and put it behind the yellow circle. And the whole idea of the token test is just to see, can people understand and follow instructions. Reading, of course, getting the person to write something, write a paragraph about themselves. Ideally, if you're suspecting there's some sort of aphasia, you've got to check or dyslexia, you've got to check their ability to read nonsense words. You get a number of naming tests, like the Boston naming test and the R bands is quite a nice picture naming test to see if they have naming difficulties. Repetition we normally do anyway when we ask them to do the digit span forwards, because we're not looking, the digit span forwards is to test attention. But if they're not able to repeat it, you must also ask yourself, do they maybe have difficulties with repetition and problems there by the arcuate fasciculus. And then verbal fluency, where you use the controlled oral word association test. I'm sure you're mostly familiar with that, the FAS. And just so that you know, I just thought I'd mention this here, the design fluency tests are meant as non-verbal analogs to the verbal fluency test. So if you're picking up on verbal fluency problems and you want to see, is this just a left hemisphere problem or is it a full frontal lobe problem, then do a design fluency test. If they do one in design fluency, you know it's a hemispheric problem, left hemisphere. And then of course the Ray auditory verbal learning test, which you use to test for verbal learning ability. And of course you would also look out for all sorts of other things while you're doing the Ray auditory verbal learning test. For example, did they hear you correctly? That kind of thing. I want to mention here dysarthria. Sometimes a person can't speak, not because there's something wrong with their brain, but because there's something wrong with the mechanism of their mouths and their larynx and the pharynx, or their tongues. And people who've been in severe accidents where their head and the face have been injured, you need to ask yourself whether it's maybe just a problem with dysarthria rather than a brain problem. Now we're going to look at spatial functioning. So we looked at language, which is more left hemisphere, spatial is more right hemisphere. And one of the things, or two of the things you're going to be covering in your Kolben-Weshaw is topographic disorientation. Now topo, or top, means place in Greek. Why it has a graphic in it, I really can't say, but just remember topographic orientation has to do with being disoriented in place. And you get topographic agnosia and topographic amnesia. Now, topographic agnosia is failing to identify individual landmarks, such as buildings. For example, you recognize that a building is a school, but you do not recognize it as the one your children attend. Or you see a church. You see it's a church, but you don't recognize it as your church. Okay, that's topographic agnosia. Topographic amnesia is the inability to remember topographic relations between landmarks. So you might recognize a school as the one where your children attend, but you don't know where it is. Or you see a Pick and Pay where you normally go shop. And you know that's the Pick and Pay close to your home, but you can't think of where it is placed in relation to your home, so you don't know how to get home from there. Then you get what they call egocentric disorientation, where you have difficulty perceiving the relative location of objects with respect to yourself, judging how far a car is from you, judging how far a glass of water is from your hand. You lose that sense of where your body space ends and begins. And often if that is the case, it's because of unilateral or bilateral injuries in the posterior parietal cortex. You also get what we call heading disorientation, where a person is unable to set a course to where they want to go, even though they are able to recognize landmarks. And many describe themselves as having no sense of direction. They walk into a shop, they walk out of the shop, and they don't know whether they should be going left or right or where they should be going. That is heading direction. And typically you have an injury in the right posterior cingulate cortex. Now you know the cingulate cortex is a cortex, that strip of cortex just above the corpus callosum. So you're looking at the right posterior at the back cingulate cortex. Okay.
Could that also be a developmental problem?
I have heard many people say to me that they struggle with this and they never had any brain injury. So yes, I do think so. And I've had some people coming to me who, I just want to mention this quickly, typically people who have Alzheimer's quite quickly reach this point where they can't find their way. But then sometimes their spouses will say to me, but they've never had a good sense of direction. So I do think quite a few people tend to be a bit like this anyway, without there being any damage. But then if somebody has always been able to find their way and suddenly they can't, then you need to know, okay, we've got a problem in that area of the brain. Now you also get what you call landmark agnosia. Now remember, agnosia is not knowing. So landmark agnosia is unable to use prominent environmental features for the purpose of orientation. So it's all fine and well, you see a familiar tree, but it doesn't help you to orientate yourself. And there that lesions are bilaterally or on the right side of the medial aspect of the occipital lobe. Now these brains down here are switched in the opposite direction to where I normally have them. I normally try and have my brains that they all face in the same direction, just so that you're familiar with it. But here, this is the front of the brain. Okay, that's the back. So that's the occipital lobe, and that's the frontal lobe. So the lesions are bilaterally, meaning both sides, or on the right side of the medial, middle aspect of the occipital lobe, affecting the lingual and fusiform gyrus and the parahippocampal gyrus. And you can see the brain on the left there, we've got the, here's the fusiform gyrus, there's the parahippocampal gyrus, and there is the lingual gyrus. And I've lost my pointer, so that's why I can't point. But if you look at the slides carefully, you will see, they are quite clearly labeled. You'll be able to see where those areas are. Okay, so the posterior side of, medial side of the occipital lobe. All right. Then you get anterograde disorientation. Now think a moment about what we learned about retrograde amnesia and anterograde amnesia. Retrograde amnesia is amnesia you have for things before the accident. Anterograde amnesia is amnesia you have for things after the accident. Okay, so anterograde is after. So the person can navigate in formerly familiar environments, but they have difficulty learning to navigate in new environments. And this you also find quite typically with people with Alzheimer's. They can find their way around their homes, but don't move them to a new house, because then they struggle to orientate themselves in the new house. Or let them shop in the old shopping center they used to. Don't put them in a new shopping center, because they struggle to find their way around, and they don't learn that environment. And there you typically have damage to the parahippocampal gyrus of the inferior ventral cortex on the right. Parahippocampal gyrus, you know where the hippocampus is. Parahippocampal gyrus is the gyrus just below the hippocampus on the inferior bottom ventral cortex on the right-hand side. Okay. I'm sure you're all getting quite familiar with all these terms. If you just break it down and just think it through, it sounds terribly complicated to talk about the inferior ventral cortex on the right, but if you just break it down and think it through, it's quite easy to understand. Now, in your studying, you're going to be reminded of the dorsal and the ventral streams. And I just want to remind you of it because it does come up again. The dorsal stream starts in the occipital lobe, goes into the parietal lobe, and eventually ends up in the frontal lobe. And your ventral stream starts in the occipital lobe, goes down to the temporal lobe, and also eventually comes out to is linked up to the frontal lobe. So both streams send projections to the frontal cortex to guide the movements of looking, reaching, and locomotion. You need that frontal cortex involvement so that you know what to do with what you're seeing and what you're perceiving. Now, there are three different types of spatial behaviors that Kolb mentions. The one is route following, where you follow a road or a path, moving towards a landmark or reaching for an object. It's purpose-driven. There's a clear road, and you know where you're reaching. It's quite clear. Then you get piloting, which is to take a course that is not directly marked by a cue or a route. You just bundabashing in a sense. And then dead reckoning is quite a complicated thing that you need to just go and look up and understand in Kolb and Wishaw. They talk about animals that use dead reckoning to understand where they are and how to get back to where they belong. And the cues that you use cues from your sensory system. And just go and read up on that.
I think men has a strong feeling for that.
I think you're probably right. No, I'm not joking. You'll see I think I mentioned earlier, next month we're going to be learning about the developing brain, so in utero as it develops. And the month after that, we're going to be talking about male versus female brain. So I'll get more to that. In fact, here we go. Here it even mentions it. All right. Individual differences in spatial abilities. It just is the case that men tend to have better spatial abilities. However, there are some exceptions. Okay. So adult males tend to perform better than adult females on certain spatial tests. Note certain spatial tests. No, but generally it is the case. But then they did some interesting studies on left-handed people, because you know that left-handed people, most left-handed people still have their language in the left hemisphere. But there's a small portion, I think it's about 20% of them, that have language only in the right hemisphere. No. About 20% have in the left and right, and then an even smaller portion only have in the right hemisphere. So studying left-handed people is extremely interesting. And they found with left-handed people, they divided them into high reasoning people, so people who can reason well, and people who can't reason all that well. And with high reasoning, left-handed males, they had lower spatial scores. And left-handed, high-reasoning left-handed females had higher spatial scores than right-handed control groups. Okay, so I'm just going to say it again. High-reasoning left-handed males had lower spatial scores, and high-reasoning left-handed females had higher spatial scores than right-handed control groups. Just an interesting little thing to ponder on. And then among low reasoning groups, the opposite was found. Something to think about. All right. Let us talk about emotion. Now, I think as psychologists, obviously, emotion is one of the most important things of what we do. We deal with people's emotions. So let's see what neuropsychology has to say about emotions. Facial expressions are not always symmetrical. Emotional facial expressions tend to be on the left side of the face, showing a right hemisphere specialization in producing emotion. Like, for example, a lopsided smile. So if people tend to have lopsided smiles or lift an eyebrow, whatever, it tends to be more on the left side of the face. Not always, but it just tends to be more because the right hemisphere controls the left side of the face and is your more emotional side. And the right hemisphere is more perceptive of faces. Okay. That is identifying who people are by their faces. Perception of emotional stimuli, the right hemisphere specialization, has been shown for correctly identifying facial expressions. So not only does the right hemisphere not only is it good at recognizing faces, but also understanding and recognizing facial expressions. And visual stimuli presented to the right hemisphere were judged more unpleasant and produced greater autonomic nervous system activation than the same films presented to the left hemisphere of other subjects. The right hemisphere tends to be a bit more morbid, and the left hemisphere tends to be a bit more upbeat and optimistic. The right hemisphere tends to be more pessimistic. And it's just an interesting thing. So you find with people who've had massive strokes on the left-hand side, for example, they would tend to be a bit more depressed. People who've had massive strokes on the right-hand side, they would tend to be a bit more upbeat. Now, there's a left ear superiority that's been shown for emotionally laden sounds, such as laughing or crying. You will remember when we dealt with the ears, when sound comes in, it goes to the left hemisphere and the right hemisphere quite directly. Okay. Of course, when one thinks about emotion, you have to think limbic system, because it's the limbic system that really controls emotion. And if you look at different diagrams, explanations of the limbic system, you're going to have different parts of the brain being included and excluded. But most of the time, you'll have included the hypothalamus, the hippocampus, the amygdala, olfactory bulb, and sometimes the prefrontal cortex. Now, of course, amygdala, when you think amygdala, you've got to think fear and you've got to think emotion. And you're going to be learning that there are three subdivisions of the amygdala: the corticomedial, the basolateral, and the central. Now, the interesting thing about the amygdala, and it's a very, very important part in our brains, is that many cells in the amygdala are multimodal. Many cells in our brain only accept one mode, for example, visual information. or auditory information. But here, the amygdala, some of those cells respond to visual, auditory, somatic, gustatory, and olfactory stimuli. Okay, so very multifaceted little cells. Of course, the orbitofrontal cortex, you know the orbitofrontal cortex is the part just above your nose here, the bottom part. If you think orbits, you think eyes, just above the eyes here. The orbitofrontal cortex, obviously in the front, also has a lot to do with emotions. And if you look at monkeys who have lesions in that area, you'll find that they'll have reduced social interaction. They tend to keep to themselves. There's a loss of social dominance. Again, they just kind of quietly keep to themselves. There's inappropriate social interaction. Altered social preference, so they don't interact well socially. Reduced affect, they don't really express emotion. And reduced vocalization, so very quiet. So if you think about a quiet, withdrawn person who keeps themselves, you're thinking a little bit more of a depressed person. And I've had quite a few clients who look very depressed. And if you test them, they test as being very depressed. But they're not depressed, they have orbitofrontal lesions. Now, people, are the only species that really have a sense of humor, according to Cole. But I think some people might disagree with that. But according to research, we are the only species that really have and understand humor. But persons with right frontal injuries responded less to humor, had diminished smiling and laughter, and failed to get their punchlines and jokes. So we know that the right frontal areas have something to do with humor. And persons with lesions of the right temporal or right frontal lobes had difficulty recognizing facial expressions. This little baby here hasn't got any of those problems. He understands exactly what humor is all about. Then we have fear conditioning. Again, when you think fear, think amygdala. Okay? So the circuits of the amygdala mediate fear conditioning. The amygdala has connections with the autonomic nervous system, as well as the hypothalamus that controls hormones. And when the amygdala is triggered, the heart rate increases, you perspire, you have bowel and bladder emptying responses, and if you think of that, then you tend to think of panic disorder. You tend to think of stress. You tend to think of generalized anxiety disorder. So when you have patients with those problems, you need to think about the amygdala and what is happening in and around the amygdala
so
and the
those
circuits.
hormones are adrenaline and cortisol, I suppose.
Yes, quite right. Now, autism spectrum disorders is something that more and more neuropsychologists are finding themselves being involved with, and involved with the assessments and the support of families with children with autistic spectrum disorders. And there's still a lot of research that needs to be done on it. So even in your Coldman Wishaw books, they just touch on some experiments that have been really important on this phenomenon. And there's a question about whether there's cerebellar abnormality in a child with autism. Because the child has a desire for sameness and avoidance of novelty, and the cerebellum controls conditioned responses. So perhaps there's something to do with the cerebellum that hasn't quite developed as it should. And also, children who with autism don't habituate. You know what habituate is? If we see something around us that is new or even that bothers us, it bothers us for a while, but then we get used to it. We habituate. It doesn't bother us anymore. Same as, let's say you live in a very noisy area, or you live in an area where there's a train that passes you. When you first move there, it bothers you terribly, but eventually you habituate. You just phase it out. Your brain phases it out. That's habituation. But it's been found that children with autism tend to not habituate. So where you maybe get used to a noisy traffic environment, they don't get used to it. It continues to bother them. And then there was an interesting study that was done on children with autism where the size of their heads and their brains were measured when they were born, and that was normal. But a year later, their heads and their brains were bigger than their normal peers, suggesting that perhaps the normal pruning that should be taking place in the brain in that first year of life is not taking place with them. And then there are areas in the caudal part of the pons, which is small in autistic subjects, and some nuclei in that area that control facial muscle movements are missing. And if you think of autistic children, they tend to have very sort of flat affect, and they also don't recognize facial expressions in others. And of course, you'll be reading about the savant syndrome, which is extremely interesting. And if you read some of Oliver Sacks's books, he talks about the savant syndrome quite a bit, and even people, not only children but even adults who have a brain injury, it can sometimes happen that by having an injury in one area, it cuts off the part of the brain that was suppressing another part of the brain. So now that the suppression isn't anymore, suddenly they are extremely autistic or extremely musical, which was never expressed before because the other part of the brain was dampening that so that it can function. All right. Schizophrenia, you can be learning about schizophrenia. Schizophrenic brains weigh less than normal brains, and their ventricles are enlarged, which suggests that they don't have as many neurons and so on. But you'll know that if a brain becomes atrophied, if the brain cells die down, the ventricles become bigger, the spaces in the middle, because, well, they're just really empty spaces, aren't they? So with schizophrenic brains, their brains weigh less and the ventricles are bigger. As I go through these sections on emotion, I'm really just touching on some facts. You will see that this is an area that's quite new to neuropsychology, and so there aren't good explanations of why this may be the case. It's really just some preliminary findings of research that really begs for more research. There's also a reduction in the number of neurons in the prefrontal cortex and a thinner parahippocampal gyrus. Why? We still have to discover. With bipolar disorder, there's a decrease in grey matter in the temporal lobe and cerebellum relative to controls. Again, in your book, there's no explanation of why that might be the case, but that's what's been found. And it is suggested that bipolar might have a progressive neurodegenerative aspect to it, almost like your dementias, just continue to degenerate. Now I'm going to touch, sure.
Mirror neurons.
Yes.
Which role do they play in the
I'm glad you mentioned the mirror neurons. When I was preparing for this tutorial, I was looking for where are the mirror neurons. You know, there must be lots of big sections on mirror neurons, and I couldn't find any, but maybe I was just looking in the wrong place. Mirror neurons play a very important role in emotion because they copy what they're seeing in other people. So, and it's an important part of why we have empathy. Because if you see somebody in pain, your mirror neurons react as if you are in pain, and that's why you can understand what somebody is feeling. And a child who has an autistic disorder, there's a problem with their mirror neurons. They can't feel what other people are feeling. And we'll probably discover with conduct disorder that you have a similar phenomenon where they lack that empathy. They can't feel what the other person is feeling. Mirror neurons are very important in social interaction because we even tend to, when we're in deep conversation with somebody, we tend to copy their body language. So if somebody's standing like this, talking to you, you're likely to end up standing like that, talking to them, because of the mirror neurons. So I'm hoping as you read, you will find lots of information about mirror neurons. I couldn't find them here, but they must be there. Yeah. They're in the frontal lobes.
And only primates have them.
Yes, that's right. Yes, that's right. Okay, now let's talk about plasticity and rehabilitation. As a neuropsychologist, when I tend to tell people that I do neuropsychology, their first assumption, well, first I ask, what is neuropsychology? And I say, I work with people who have brain injuries of various sorts, and they say to me, what do you do to help them? I think, well, it's horrible to say, but there's not much I can do to help them, but what I do is find out what's wrong with them, which sounds terribly cold, but it does ultimately help people if you can tell them what is functioning and what is not functioning, and how to, what to prepare for in the future, and what to expect and whether it's going to get worse or get better. So in a sense, by doing neuropsychological assessments, you do help people, but you can't help them get better, and I want to talk about the word better in a moment, unless you're doing rehabilitation, which is a different aspect of neuropsychology to, for example, what I do. But a very important area of neuropsychology, and I think we have a huge lack of psychologists doing neuro rehab. Now, to help somebody get better after an injury, it doesn't mean that you help them recover. It does mean that you help them to compensate. So, as you know, brain cells cannot be revived or renewed. If they've been damaged, they're damaged. There's nothing you can do about it. However, we have the phenomenon of cerebral plasticity, where the brain sometimes transfers functions to other brain areas. Now, whether or not it does that depends on a number of things. One of the main things it depends on is what age the person is when they have the injury. Because if they're still in the age where their brains are still developing, there's a greater chance of plasticity taking place compared to an adult whose brains have stopped developing. But even in adults, you sometimes get transfer of function to other brain areas. Also, unfortunately, then get wherever that function has moved to, the function that was there gets lost. So you get what they call a crowding out effect. You get, for example, children who have left temporal lobe epilepsy, and the temporal lobes get disconnected from the right temporal, the right hemisphere. So the whole left hemisphere, gets disconnected from the right hemisphere to stop the epilepsy. And that is an extreme thing to do, but that is really if a child is getting such severe epilepsy that they cannot function, then you actually separate the two. Now, what often happens if you catch the child at the right age, the language functions move over to the right-hand side, because our brains consider language as being a very, very important part of our functioning. So language moves over to the right-hand side, but what tends to happen is the visuospatial things get crowded out, and you'll often find that they'll have spatial difficulties. Okay. Of course, if there's brain damage to certain cells, you do get cells around them that can sometimes send out more dendritic branches and make new connections that can help further functioning. And then sometimes, in some disorders, it looks like there's some spontaneous recovery, especially with traumatic brain injury or stroke. But what often happens is, with traumatic brain injury or stroke, you might have a swelling of the brain around the area, and once the swelling has died down, those brain cells function better. So for a while, the person might be performing much worse, but then over time, it looks like they're recovering, but it's really just those brain areas can function a bit better. And then one of the roles of a neuropsychologist in helping people compensate for brain injury is helping them deal with tools. Now, a tool can be anything from a walking stick or something to help them physically to brush their teeth, to, for example, using cell phones. I heard a very interesting presentation once on rehabilitation of patients with frontal lobe injuries. And you know that people with frontal lobe injuries, they have great difficulty planning and thinking ahead. So cell phones have become very important parts of those people's lives. They have to, of course, remember to program the cell phone, otherwise a family member has to program it. You've got an appointment at this time, now it's time for you to start making your food, now it's time for you to start preparing to go to bed. And through the use of technology, there's quite a lot that one can do to help people with brain injuries. And then sometimes just the way a person approaches their own body, the way the change they make to their own body helped to compensate. I recently assessed a little boy who'd lost sight in the one eye, and when he watches TV now, he turns his head so that he can see better with the other eye. And then one can help a person's functioning tremendously if they have improved social support and if they have improved emotional support. So there's a lot that we can do to help people. And then, of course, you have the whole area of research into stem cells, and you can go read up a bit more about stem cells, where you know what stem cells are. They're the little cells that start off not having a function, and they develop a function as they develop, depending on where they are in the brain, where they move to. And so there's a lot of research into taking stem cells from, unfortunately, from embryos sometimes, but in the umbilical cord you also get a lot of stem cells. So stem cells from there, and seeing if one can change them to take on certain brain functions and then plant them in the brain to see if they can take over new functions. It's still quite new research. There's still got a long way to go, but it has a lot of very exciting prospects. Now, plasticity in the brain is a fascinating topic. For example, motor training can change the size of the components of motor maps in the brain. For example, a violinist, they use their left hand to essentially play the violin, because the left fingers have very intricate movements. And by practicing violin, the area in the brain that controls that left hand becomes bigger in your brain. The same as if you're a pianist. Those motor areas, in this case with both hands, become enlarged. So you change the cortical maps in the brain because of plasticity. You'll read about an interesting experiment that was done where people had glasses put on, prism glasses, that turned the world, everything they see, upside down and the wrong way around. And it took a day or two for them to wear that when they continued wearing the glass, but the brain flipped it all the right way around again. So everything looked the right way up and the right way around. And they wore it like that for a few days, and once they took it off, of course, everything was upside down and the wrong way around, and it took a few days for the brain to switch it around again. The brain is really has an amazing ability to adapt. And there have been various studies that have shown that early blindness in a young child results in the expansion of the auditory responsive areas in the parietal and occipital lobes. So not only do they hear sound, and it doesn't just go to the temporal regions, but even into the parietal and occipital regions, because those they can't see. So the occipital lobes aren't used all that much for vision, so the auditory functions tend to move that way, which makes them extremely good at hearing. But there are some negative sides of it, and you get what you call focal hand dystonia, where some musicians find, after years and years of playing, the representations of their fingers in their brain become so wide that they start to overlap, and the fingers in the brain actually become fused. So in the brain, you've got your little finger in the brain, and next to it your ring finger, and those areas spread until they linked up, and then they actually can't move their fingers because they can't move them independently. And this is quite a problem that a lot of musicians face if they really play music for a long time. There's also been extremely interesting research done on phantom limbs. Now, when we have an arm amputated or a hand amputated, that you still have a representation of your arm and your hand in your brain. So you might experience an itch or pain or discomfort in that hand, even though it's not there because it's there in your brain. And Dr. Ramachandran did some interesting work on phantom limbs where he took a mirror, as you can see in the picture. And let's say this arm has been amputated. He gets a person to stand with the mirror over here in front of this amputated arm, and the person puts their right hand here. And they try and move, while they try and move this hand and try and think that their other hand is doing the same movements. And eventually they can actually, it feels as if they've got this hand again. And why it helps is that if there's been pain or discomfort or an itch, then they can scratch it. You get somebody to scratch that hand in the mirror, and they feel as if their hand is being scratched or corrected. And apparently the movements in a phantom, or the sensations in a phantom limb, have very much to do with what the position of the arm was before it was amputated. So, for example, if the person was in a motor vehicle accident and the arm was twisted before it got cut off, that twisted sensation can remain with a person, which is extremely uncomfortable. But by using these mirrors, you can untwist that arm and just make it far more comfortable.
So you trick the brain.
You trick the brain into thinking that your arm is actually there, and so you straighten it or scratch it or rub it or put ointment on it or whatever you need to do to try and help that arm. And then, as I mentioned before, the ability of the brain to recover from injury, when I say recover, you know what I mean. You're not really recovering, but you're compensating. Very much depends on the age of the person and where the process of development of the brain is as we go along. And you'll be learning more about that next month when we do the developing brain. And this is your required reading. It is quite a lot, I must tell you, because there are 5 big chapters that you need to go through and then just a couple of little parts. Again, extremely interesting, but try and push through and go through all of it.